Hello, our lovely viewers. We are up on your screens once again to bring you Mom's Heart Talk Show. This is where we give you the holistic view of health for our ladies, especially you moms on a journey of pregnancy. Last week we had a nice episode with our guests on the first visit when you are pregnant, when you go to the hospital, what you should do, what you should not do, the food to eat, what you should not eat. We are continuing this journey today, and today we have another interesting topic from our guest and to also give us more insight into it. So viewers, our topic for today is a routine visit to antenatal. That's what you expect when you go for antenatal on your subsequent visits, and also look at the common disorders that comes in pregnancy. We have our expert guest as usual, Madam Mary Ejare with us, who is going to do this honors with us, give us the diverse explanation to all these topics for us today. Madam Mary, you are most welcome in Mom's Heart Talk Show. Honestly, very much, because you'll be with us throughout the journey, and our viewers are really enjoying your explanation, the professional tips you'll be adding to us. We are very most grateful. Thank you for today to be with us.
You're welcome. And I'm happy to be here too.
Thank you. We've come a journey where we were not pregnant. Now about fertility, we are pregnant. We've been to the hospital for the first time, and then we are to go for subsequent visits. When I go, what should I expect? Why shouldn't I be in the house when it's time for labor? Then I just go and deliver. Why should I follow up on the next visit we give?
Okay, so thank you. So we have to follow up because, like we said, pregnancy has its own issues. So now that you have gone for your first or your booking visit, anything can change between that time to when you deliver. So it's better that you go on regular visits so that we check and see whether things are going on smoothly. Sometimes you can be there, especially in the first trimester, when you don't feel the baby moving. You can be there and the baby might even die and you don't know.
Wow.
Yes.
In
the womb, the baby might be dead, and now everything will cease. There is no movement, there is no growth, and you may not even know. So you know that you are pregnant. Scan confirm that there was a fetal heartbeat, and so you think that your baby is there. Meanwhile, baby or something might even have happened to the baby without you knowing, or something is even happening to you that we could have solved if we had known earlier. And so it's better that you go for regular visits.
So if I go for regular visits, I've come today to see either the midwife or the gynecologist. What is there for them to do for me?
Routine things that will be done for you.
Okay.
So a blood pressure, the last time we talked about it, that pregnancy can increase your blood pressure. Pregnancy can reduce it. So we have to check it at every time that you come. So every time that you visit the antenatal, your blood pressure will be checked to see whether it is within the normal range or whether it is going high or reducing.
But is it normal when you are not pregnant? Is there a difference?
Yes. So normally, as we said, the pregnancy in itself can increase your blood pressure readings.
Okay.
So when you visit the antenatal for your subsequent care, that one, when we check it and we see that it's still within the normal range, then you are safe. Then you can continue. But sometimes when we see that it is increasing, and when you attended the antenatal for the first time, your booking, it was normal, and we check the number of weeks that you are in, then we can say that the pregnancy is the one that is causing the increase in the blood pressure. So sometimes we need to check it. That's why we need to check it routinely so that we are very sure about your reading. Then also we check the blood sugar. So the blood sugar was also checked during the booking or your first time. So this time is also going to be checked. We want to be sure that pregnancy is not making you have sugar in your urine or protein in your urine. So, because when you have protein in your urine, it is suggestive of something. When you have sugar in your urine, it's also suggestive of something. So we don't want to have it. And when you have it and it is mild, we are able to resolve it early so that it doesn't get to the complication stage. So we have to check it. So it's also part of the things that will be checked. Then your weight. Every time that you come, you have to check your weight. As we said in the previous episodes, we said that you need to gain a certain amount of weight, that is 12 to 15 kilos, throughout the period of pregnancy. And so we expect that weight gain should be distributed throughout the 9 months.
Oh, okay.
Yes.
Not
So
at a
no,
go.
not at a go. So at every time that you come, want to see how much have you gained at this time that you came to visit. And so when we check, probably you are gaining weight gradually. That one is okay. Or you are not gaining weight at all. Then we say that there is something wrong. So your weight will also be checked.
So your weight also can it determine the weight of the baby?
Definitely. Or how much you are eating well, or that's your nutritional status. It will also help. And sometimes, when you took your first scan, it will tell you, it will give an estimated weight of the baby, at the time you took the scan.
Okay.
Then you'll be told when to take maybe a second scan or the last scan. That one will also tell you the estimated fetal weight. So you'll be able to calculate and see how much weight the baby gained and how much weight you also gained yourself within that period.
Okay.
Then also, when you come for the subsequent visits, we have to also check to see, we prevent malaria in our part of the world.
Yes.
Malaria itself affects pregnant women. The outcomes of someone that has malaria and pregnant is not good. It can lead to anemia in pregnancy. Malaria in itself. It can lead you to lose your baby or to have a preterm delivery. It can also lead you
to malaria.
The malaria that we know. Malaria is worse on pregnant women.
Okay.
Yes, so we don't want pregnant women. So if you can protect yourself from malaria, do so. That's
when you
are pregnant. That's why we talk about sleeping under the insecticide treated nets, especially when you are pregnant, because malaria is worse to a pregnant woman. It's believed that there is some odor that the pregnant woman emits that attracts the.
Is it?
Okay, science has proven it. And so the female Anopheles mosquito comes closer to the pregnant woman more than any other person.
Okay. I heard it, but I thought it's one.
No, it's true.
Oh, okay.
So
they have some odor that attracts
the mosquitoes, and there is the mosquito, the infective one. So it attracts them. So now we want the pregnant woman to be protected from malaria, because when you get malaria, it is very severe with you than with a normal person, a normal adult who has gotten malaria, normal malaria. And so, as part of the routine visits, now we give the SP or the sulfadazine pyrimethamine. So we call it the IPTP, the intermittent preventive therapy for pregnant women. Yes. So we normally, it used to be 3 times, but it has been increased to 5 times. So you are going to take it for 5 subsequent times within your pregnant stage.
To prevent
malaria. So as I said that malaria can make you have a preterm delivery.
Okay.
It can even cause your baby to be small for age. So you realize that you might be 10, but the baby will be very small when born. Malaria can cause that.
Wow. That is serious.
Yes. So if sometimes I know we discussed in the previous episodes that sometimes because of GSSPD, so you cannot take sulfur drugs, and the SP that we give is made of sulfur. So with that, then you try so hard so that you use the other methods of malaria prevention. So
is
for
there
you,
any medications?
no.
But there should be at least
Other
yes,
some
for those who are
most of our anti-malarials are having sulfur.
Oh, okay.
So for you, when it comes to the sleeping under the net, you can't do it. You have to sleep under it because you don't have another protection.
But this sleeping under the net is a whole topic on its own because even those who are not pregnant, we are not even saying when you are pregnant, there is a heat.
Mm-hmm.
And you are not even comfortable yourself and going to sleep under the net, the comfortability, like pregnant women think about their comfortability before thinking about what will infect them.
Yes.
So at least they should do something. You should have some other medications to supplement the sulfur medication.
Yes. So currently this is what we have. So if you think about maybe your baby, having a healthy baby, and thinking about your comfort, I'm sure you will choose having a healthy baby because the time is just 9 months journey.
Yeah.
But after 9 months, whatever you bring out is yours.
It's yours.
So if you could contribute to why don't you forgo your comfort so that you will come out with a healthy baby?
Yeah.
And yes. So you try to adhere to what will be told. If we say you should sleep under the ITN or the mosquito net, make sure you sleep under it so that the baby will be healthy.
But when do they start taking the SP?
So the
Which
SP,
month of the pregnancy?
So the SP is taken after 16 weeks.
Okay.
So at 16 weeks, you've entered your second trimester because the first trimester ends at 12 weeks. So 16 weeks, you've entered your second. So it will be part of the subsequent visits when you go.
So before 6 weeks, how do they take care of themselves? Because they are not giving them medications.
So that is where the net comes in.
Okay.
That's where any other thing that you use to protect yourself from being bitten by the mosquito. So either you spray your room or make sure you use trap doors or you don't stay outside too much into the night, or you make sure that if you have to stay, then you make sure that you wear long sleeve dresses. You prevent so that you do all that before you are now giving the SP at the 16 weeks pregnant.
So even though you are on the SP, you still need to
protect yourself because it's likely that you might be on it, but you expose yourself to the mosquito, then now you get infected.
Okay.
Then another thing that is also being done is the vaccine, the tetanus diphtheria vaccine.
Okay.
That's also given. So there is also a schedule that will be given, that will be followed. So sometimes, normally with the EPI, the immunizations for children who are like 15 years down, now they've included the tetanus in the penta.
Okay.
So these ones have already been protected. So they will only come for booster when they are pregnant.
Okay.
But if you are like 16 years upwards, those times the immunizations that were given, tetanus was not part. And so we have to go by the routine schedule.
Okay.
So with that, the first one that you are given has no protection. And that one is given at your first contact. Then you come 4 weeks after for your second dose. So that one will give you some form of protection. Then the third one will be 6 months after the second one. Normally, most people by that 6 months, either they've delivered or they are near delivery. So when they deliver, we tell them that you can visit any facility, then you get your third dose. Then the fourth one will be 1 year after the third one. Then the fifth one also be 1 year after the fourth one. So all those times, if you are not pregnant, it means that you are at home. So you should go to any facility to continue the schedule.
Okay. So the tetanus, the diphtheria, what does it prevent you from?
So it prevents not necessarily you, right? It prevents the baby from getting neonatal tetanus.
Okay.
Before the baby is now given the routine immunization at 6 weeks. 6 weeks when they start getting the tetanus by themselves.
Okay, so does it mean that it protects the baby only when the baby is in the womb?
So it protects the baby when the baby is in the womb, and the first few weeks when the baby is born, before the baby is now given the routine vaccination for the baby itself to also have her protection or his protection.
Okay, okay.
So when you are given the TD, it's going to protect the baby.
Oh, okay. So both like dual protection.
Yes.
Get. Oh, then that's nice.
Yes, so you have to always go for it.
For it.
You also be checked the palpation. You'll be checked that how is your baby doing,
Okay.
is your baby growing. So all these things will also be done at the subsequent visits. So when you come, you expect that you have to go through that
How would
too.
it is scan?
No,
Light takes
so
time.
the scan you don't have to take it at every time that you visit.
Okay.
So your routine ones should not include scan all the time, but that one will be done by your midwife
Okay.
or by your doctor. So the regular test, so the palpation will be done with them. It's a skill.
So that's why you lie on,
On
the bed.
they'll
and
tell you
then-
that make sure that you urinate before you lie down.
Oh, okay.
So once you urinate, then you lie down on your side, then you see that they will be doing this, then they'll be checking to see, they'll check where how the baby is lying. Then they will now use the Dopplers to take the heartbeats.
Heartbeat.
So you will be hearing that it will be doing pom pom.
There's
pom.
one they will use something.
That's the
instrument.
fetoscope.
Then
But now
they
we've gone
hear-
past that.
Oh, really?
Yes. Just that now.
So what do they
you can
use
still-
now?
So that's why we use the Dopplers machine. So
Okay.
that's what we use. So that one, when we put the gel on your tummy, then we put it on. Then it will be picking up the heartbeats.
Okay.
Then later when we locate the heartbeat, then you now see that it will be doing the pump. Then it will record the time for us.
Wow.
The readings.
Readings.
So sometimes you see that they'll write 138 as the fetal heartbeat, or sometimes they'll write present, the fetal heartbeat is present.
Oh, okay.
So that one.
Oh, that's
We
now they don't
do
use
it. No,
the fetus.
no. Unless
Okay.
in very extreme
Remote
cases,
areas.
then you go and use
When you go
that.
to the remote areas that
If
they don't
they
have
don't have-
electricity or those things, they have to use
And the danger with the fetoscope is that normally when you put it on the mother's tummy and you are not very careful, you'll be hearing the mother's pulse,
Okay.
and you might record it that one is for the baby.
Okay.
So we had to move away from that.
From that. All right. So with the palpation, I know you were able to locate the back, the front, the head. How do you do it?
And so that's why it's a skill. So as you do,
So not anybody can do.
No.
If I put a pregnant woman on my
and you want to
table
do
like
it, you
this
will
and-
not, you'll just be feeling everything around.
Really?
So the more you do it, you see, you become experienced.
Okay.
So you'll be able to know that when I feel the smooth part, it's either it is the back or I'm feeling the bottom. Then when I feel the rough parts, then you can see that it's either it is the toes or it's the fingers. Then when I feel the cup shape, then you can see that this one fits into my hand, so it will be the head. So that one it comes with
But like can a
experience.
pregnant woman herself does that?
You can't.
You can't do it.
You can't.
You can also be massaging.
The what you can do is
Because
that
baby cakes.
yes, when the baby is kicking, when the baby moves, there are sometimes that they can give a very painful kick. Then you can hold and say, what I'm holding, it seems that it is either the upper limbs or is the lower limbs, because you can see that it's rough.
Okay.
Or sometimes too, they can kick with their elbow. But you cannot really say I'm feeling it, so I can feel the baby's back, or no, it's
That one
impossible.
It's a nice skill. We have to come and learn. I have to come and learn it.
Okay.
So that I can at least, when I'm pregnant, I'll be doing the palpation, whether my baby is lying well or it's lying right
Yes.
or lying.
It's like-
It helps rather.
Yes. It
Oh,
helps.
that's nice.
So we'll be also be able to see how the baby is lying. You see, some of the time the baby can be lying with the head down.
Okay.
Head down, then sometimes the legs are up, or the legs, normally babies lie in the fetal position. So the fetal position is when they do like this.
Okay.
Most of the time the baby lie in this way. So that's the fetal position. So when you can, it's very few that you see the baby is lying front position, their legs are down here. No, most of the time they curl themselves like this.
Okay.
So it's easier for you to locate the back.
The back.
That is where we normally listen to the heartbeat. So when you proceed, when you are able to do all that, you palpate and you get the back, then you are able to see that this time the buttocks is up. So the back is here and the head is this way. So it means that the baby is with the head down. So that's the cephalic position.
Okay.
Or sometimes the bottom is rather down. So that's the breech position.
The bottom is down, the head is
The
down.
head is up. So that's the
On the
breech.
pictures that we see Okay, sometimes you
Understand?
see like pictures of like the fetus, the way it is in the womb. Sometimes you see the bottom up, the head curl like this, and
Yes.
sometimes I know they said the head comes down only when you're about to deliver.
But some does not even come down. And you see, when the baby is growing, the uterus is also growing.
So
they keep changing positions.
Oh, okay.
But as they keep growing and you are getting near term, because they are also growing, they now take up the space of the uterus. So they cannot move as fast as they used to move when they were small. That one they could move. This week you see that the baby is lying down with the head down. The following week the baby has turned, the baby is rather lying transverse.
Wow.
Then the other week you now see that the head that was down has come up because there's so much room and they are moving around. But as they keep growing and they are getting near term, then you see that they cannot move as they used to move. So sometimes if the head is down, it can remain down, then you deliver. Then sometimes if the head is up, it may not change. So it will be the bridge till delivery.
Wow. Does it have consequences?
So
for the normal one, for the head to be down.
So
if it's the buttocks down.
So if it's buttocks down, that's why I said sometimes it depends on how, if the legs are also down. Some of the babies, when they are coming, by the time you are checking them, is one leg that is coming up.
Hey.
So if one leg is coming down like this, then you realize that this is someone who hasn't given birth before. The place is not so. And when you compare going through labor with this person, probably is in a health center, going to maneuver, it may not be possible. So that one is an indication for cesarean section. So you have to refer. If you cannot do it at your place, you refer. And the baby, the mother and baby are pushed to a place where they can perform cesarean section until the baby.
We will talk about that at that time.
Yes. But sometimes some of the breach, maybe the mother has delivered before, or it is a facility that we can do something. You can maneuver and deliver a breech baby
with your hand, or
so you will take it out slowly. So sometimes you can bring one leg out, the baby will turn small. You bring another leg out, you put the baby out. Then later you bring one arm out, you bring another arm, then I take the head off. So it's also done.
How do you put your hand inside and turn the baby? And just turn the baby. My dear, come with your head.
There used to be a procedure called external cephalic version. That one they used to turn the baby when the baby was breech, which is the bottom down. They used to turn the baby for the baby to now come with the head down. But it had a lot of complications. So now we don't do that.
You don't do that. Hey. It's like you are delivering parts of the body.
A bit, yes. So
wow.
then
that
gradually
needs experience midwife.
Needs experience. So you cannot just go to someone who is not so qualified and you go with a breech and a person can deliver. It might be that the woman will suffer, the mother will have maternal exhaustion, and we might even lose the baby. Because the more the baby keeps there, oxygen supply is reduced. So the baby may come out and may need NICU services, and at that place you may not have. So referring the baby, our referral system, it's so many issues.
The referral system is not good. Yeah, I don't know. I don't know.
Sometimes we say that we should prepare, we should plan. And now you plan, even when you say the mother should even give 2 pints of blood, because in case of emergency you might need them. There are so many stories about that. So plan. They think, I've delivered before, nothing will happen. And you might deliver somewhere. You might not know. And now when there's drastic change in the condition, then you need attention, and now you have to either be moved from that facility where you are because you don't have the equipment to go for the next level of care. So you have to be moved to another place. And now transporting, a traffic situation, transporting the person from one facility to another where the person can receive advanced care. There are so many issues.
So these are some of the things that brings about maternal death and then child death.
Complications about it, because now let's talk about something like the child needs to be delivered.
Yes. And when they want to come out, they want to come out.
Yes.
No break.
Needs to be delivered, and now there are so many things that are lacking at where you are. They need to be sent to a facility. Now which is far, or you are even having to call, and they tell you probably there's no bed, or we cannot receive, so call another facility. So many issues come to it, and there are some things that could have been prevented within those times, and now we couldn't do that. Now the baby comes out, and there are so many issues. From cerebral palsy
mainly on, like, you know, when there are these complications like this, and that results in maternal death or childbirth, we put all the blame on you midwives. But like, looking at what you're saying, we should also plan for these emergencies. At least a vehicle should be ready in case of emergency. There's people around, or caregivers, guidance, or people to help you if you need to buy this. It's not that maybe one person came with you. The person will be running all around, errands, do that. So I think we should plan all these things, and then the midwives for the health system also do their part.
And you know, sometimes when you sit under a maternal audit or perinatal audit, you understand some of these things. You know, sometimes the mother would have come for antenatal. Then looking at the history, looking at what is going, you tell the mother that, please, when is delivery, don't come here. Proceed to this place, or even before you even get into labor, make sure that you go and see a doctor for him or her to also assess you, to be sure whether you can deliver. We also have some that are very stubborn. You tell them this, and they say, no, you are the one that have been delivering me. Kolebu dia hwan na menim no wo ho, rage dem ekoye den wo ho na aha na me on aha na me pe. And so at the time when labor set in, you yourself, you know, you can project and see that
You can't.
at the way it may end. Some are lucky, maybe a BBNC, then fine. But some too, na bibi akwa kosi. And by that time, you see, we didn't plan for that. That's an issue.
But when the person can, let the person go to the
Obiaba, washa that now. I want them to him send ya wanna, but what's now? Opa and Anchana, baby neighbor. Oh, who considers sending that person? I mean, I want to pay. Oh, so you want to do something?
at least.
See, the issues are many. The issues are many.
When it comes to pregnancy and its delivery, I know that there are a lot of issues. But one thing I've realized is, even you as an individual who is getting pregnant, your pregnancy is different from other pregnancies that you are pregnant.
Yes.
So there is not like, oh, media me say yeah, every baby and how it's pregnancy.
And the condition can change suddenly. You may have no idea. Personally, I know a mate that delivered. She delivered a set of twins. So is the twins that were having issues, so they had to be taken to the NICU and others. Then suddenly the mother's condition changed. So it's the mother, sadly, that died and left the twins.
Wow.
Sudden change in condition.
Wow.
And by the time we were able to resolve it, it was too late. Oh. So the mother rather went.
It was all attention were on
the twins. And so things can change at any time.
And we need to take our visits very, very, very
and
serious.
And take whatever will be told you.
Prevention is very
important. You tell them something and they don't want to.
Yes. Is it not that when they come for this regular visit, I think we should share these stories with them to let them know that there are consequences or effects. If you don't do this, this will happen. If you don't do this, this will. Do we tell them that? So because if I know I don't, like, I just got frightened with the malaria. I know malaria is a common thing that even now it's a test and treat.
Yes.
People will say, oh, I know my malaria. I have to take this or take that and then I'm okay. But the way you are talking about malaria in pregnancy can result in the child being dying, low birth weight and other things. It's serious. So if I tell you that take this SP, if you don't take this, do we do that?
We tell mothers And we tell mothers as much as we can. But you see, no matter what, you will have people, and people will feel like, oh, I know what I'm doing. I've been through 2, 3, 4 times pregnancy.
So they have evidence.
So I have evidence.
They have evidence to prove to you
that yes, I know what I'm doing.
I know what I'm doing.
Yes.
Wow. We shouldn't know more than the midwives. We shouldn't know more than our health workers. They are more experienced and they meet different cases, different people, different set of pregnancies and AIDS complications all the time. So they foresee what we can't see. So if whatever is being told, please just follow it, and I think we will have a safe delivery with a healthy mother and a healthy baby. Madam Mary, let's continue with, now that we've seen the routine, everything. Now, as we were talking about the malaria and its complications, what are some of the common disorders that this one, when you see it, maybe it's a red flag, you need to hurry up or something? Does it that pregnancy have disorders or those complications?
So we have 2 main things. We talk about the danger signs in pregnancy. Okay. Then we have the common disorders that you can have in pregnancy.
Okay.
So the danger sign, that one, when you see one, you don't have to sit and wait to see the other one. So because we want mothers to remember it, normally at the back of there's the maternal child report.
Maybe I'll be getting pregnant soon.
So at the back of it, we put the danger signs during pregnancy there. Okay. Then we have the signs of serious illness in a child. Because it's a new one. When it used to be the one for just the mothers, then this one was broadened at the back here. But now this is combined, so you can use it for pregnancy. Then when you send your child to weigh in, it's the same one that you use, using the same. Okay. So now we have both here. Oh, okay. So these are the danger signs during pregnancy. So we'll come to it. But before that, we want to talk about the common signs that we see. So as we were discussing, we've mentioned some. So the nausea and the vomiting. Okay. So these are the normal ones. You know that we talk about nausea that is caused by hormones. So it's common that you see that with pregnancy. Or maybe you want, mostly in the first trimester, you have a lot of nausea, and some too have excessive spitting. For some, that's how they are. So they can omukita container kakana pill no di tutum.
Oh,
pregnancy. See, that one is not a danger sign. Pregnancy humbled me. So those ones are not danger signs, but it is a common disorder. So once you have it, you know that.
So like with your normal life, you don't spit.
You don't spit. Until with container to spit. But this is what pregnancy has given you. So it is a common sign. Another common sign is the marks of pregnancy or the cloasma. It's cloasma no nema obi must say oh nyama na opena yekese o. And you said they darken. Obi anka hu san koye kama smooth face. Na fe ohwe nipa na say eh, the person really changes.
Okay.
So we call it the marks of pregnancy.
Oh,
so we there. On you, especially when the pregnancy is advancing, no, also so name may advance fine. Debbie, and no other you are. See, I don't crowd the fancy, and also a common disorders, see, any complication, any danger sign. So you should not be so worried that when your marks of pregnancy, it will go back. And your hormones are didn't back. So the nausea is past the spitting. It's by now cloasma. And changes in skin. Normally, you say there is a black line. It starts from under the breast, throughout on your tummy, the navel, then it goes down. Okay. We call linea nigra or the black line. And so a pregnancy in the device. Changes in the skin pigmentation. Most of the time you see it in pregnant women.
But so when you deliver, the line goes.
It will not go entirely, but the darkness will reduce. The darkness will reduce. Then stretch marks. Pregnancy brings stretch marks. So that you realize stretch marks everywhere.
It's not stretch marks in pregnancy at the back.
At the back.
But it looks like it's nowadays that it's associating with
Because
pregnancy.
we are becoming very used to it too.
Yes.
We are becoming, and sometimes it's because of our skincare products.
Because I think previous years you don't hear stretch marks with pregnancy. You don't even hear about stretch marks. And nowadays you can even see a child 10 years on stretch
marks. And they say because of the sort of products that we are using.
Okay.
But pregnancy in itself brings stretch marks.
Okay.
You find it where your breast,
maybe because the body is stretched.
That's also part. When that one, a hot there worse. A hot there because of the uterus no enlarge there, it goes with the skin and stretch marks no be more.
Okay.
And pregnancy in this one will also enlarge your breasts. Because it's preparing for breastfeeding. Nature nanka says yes, your breast milk no. So when you deliver and you have nothing that has been told and you decide not to breastfeed, that won't have a banner. Because the nature has already prepared your breast for you. Nature has put breast milk inside that, give it to the baby. While plan also made their main breastfeed. Once if you have the capacity, unless maybe something so you cannot breastfeed, that one there's nothing we can do about it. Then sometimes fainting is also a common disorder, so you can't say especially first trimester. Social movies no before I read it, so being no say oh no fainting no fainting. The fainting is or feeling fatigued. So since onion so bread and also now almost I am a member the end to be answered. A plan in your man. You want say a plan in your man or what the judge man not one or what done. None of my bonus yeah, so feeling fatigue is also another. It's a common disorder. So extremely tired. Pregnancy. And all there. Going on, you can't say it will stop in the first trimester because second trimester, and once the uterus is also going, it's going to give you backache. Because normally in Kawujina, how we are normal, but now your posture starts to change. Now you start moving ahead. Your center of gravity starts moving ahead like this. So, by the way, ordinance so this is no ordinance.
It's a new life.
There you
support.
Support.
Pregnant women for no trust one.
So backache, waist pain, because your posture is shifting forward, so it affects your back, it affects your waist. It is also a common disorder, a danger sign. A common disorder. Then varicose veins. It becomes enlarged. Varicose veins, normally it even walk behind their knee. It's a pure or pants. Won't say or bands. But you have to be very careful. The danger is that if something pricks it, will be bleeding. So you have to be very careful. If only varicose veins, you have to be very, very, very careful and know what to wear so that you don't prick it for you to bleed. And also it normally happens. It's also a common disorder. It is not a danger sign. It goes back. It's not a danger sign. The other one is heartburns and indigestion. So normally you realize that most pregnant women they cannot keep their food. So either there is because of the growing uterus. It presses on your stomach, a press on diaphragm. See, a back. Most pregnant women have that complaint. Heartburns.
So how should they eat to prevent that?
So you avoid spicy foods. And I don't know, you say we don't want you to eat one at a go. Make sure you portion them. So if it's in bits, it goes down easier than when you eat one large meal and it's not able to go down. So you start to feel to say, okay, so na age 29. One share is easy for you to vomit everything that you're eating. So you eat in bits.
Okay.
Eat in bits. So when you avoid the spicy foods, when you avoid the peppery foods, you also avoid oily foods.
Okay.
Because oily foods can also let you have the heartburns.
Okay.
So another thing too is the food aversions. It's also a common disorder. Say, if you're not cow pepper all of a sudden, and you will now they're not one person so now if you're when you're so a cravings never ban 2 a.m. if you're watching the squam po baby Amelia or tea or only watching a mepe.
Oh, now come on. So it's a disorder.
It's a common disorder, a hormone. There's nothing you can do about it, and it's not a danger sign.
Okay.
So it's something we should manage it. We should make sure. And yeah, just a woody and up in water.
Woody and water. What mean the on this shape?
A bit more dear or say, or go on more say or pie. Not let it be one of the rural areas who are on Nama Ponchibun when you come. What's an asset? Cobbets Massa. Here you are not a fine enough for sorry.
Wow.
But ordinarily, you wouldn't have done this. And see, and also so they are there, but
another story about where they are not. Everybody on my shade, they can share those stories.
But now, so what person with your boss or so on insane. After you can boxes and one or shit. And also, and one share.
And another is a craving. It's not about food alone.
It's not about food alone. It's not about because of the heat that you talked about. Or no, now woman say that was so AC was so fun. And the husband that airport so you know cry. No, so no. So it is not a danger sign. It's a normal disorder.
Pregnancy, so that you're normal.
Pregnancy, so
yeah, normal. No, you're normal.
And you're normal, my see, okay, very chilled water.
I want my blog.
Your blog into 10 beer day blog. I say you're feeling hot inside. But we all caution ourselves, say moderation. Oh, I didn't get cravings now, but control yourself small. But at the end of the day,
sometimes sooner you betray your do.
I know, dear.
Because when you my young crocro, especially with first child. Precious babies. Special babies, you know. Any open you can moon crab at your it's you know, a man who said the fat advantage.
But you can imagine that way a normal pregnancy. So you can imagine someone who is pregnant with twins and having this cravings.
So they are having double
cravings.
Everything will be double.
Can you imagine?
Quadruplets. Wow.
So those ones are also there. And so still manage yourself and also increase urination. See, and also so your common disorder and your danger sign. See, because of its present. The last time we talked about, we said the first trimester and the last trimester, or when you're getting to term, you say, oh, I don't so the no produce, oh, I don't so the, and don't just say, oh, you're not baby, but a insane and the other. So with time, you'll be okay.
Is that not a sign of diabetes in pregnancy?
The frequent urination. So the diabetes in pregnancy mostly will come from the urine sugar that one we test, but not really from the frequency. Or frequency, because of the uterus, definitely you have the frequency.
Are we done with the common?
Then other ones that we'll have is the numbness in the extremities. They will come and complain with that a lot. Okay. They'll tell you that they don't feel their fingers. It's also a normal one.
Okay.
It's a normal disorder. So with time it will go away. With time it will go. So it's not something that we should be so much alarmed that maybe it's a danger sign. No. It's also a common disorder. So if it's not the fingers, sometimes it's on the toes. They feel it. But so we'll tell you that if you begin to feel that not one can massage your so that the blood will flow to the extremities. Okay. So it's also another. Then lastly, palpitations. Palpitations. Oh, I won't ask what is our hormone. It's all the hormones in pregnancy that is causing it. Wow, what's a kum? Now, what is our kum? Wow, what is our kum? And yet it does not go on for, and it's not as common as nausea and vomiting and as eating other things. No, it's not as common as that.
It
just comes once in a while.
Wow, viewers, we've really learned a lot. Thank you very much for staying with us. Follow us on all our social media handles on Mom's Heart Foundation, YouTube, Facebook, Instagram.